Entonces, invitamos a la charla de la doctora Amanda Ombrello. La doctora Amanda Ombrello nos hablará sobre déficit de DADA2. La doctora se licenció en medicina en la Universidad de San Luis, en Missouri, y ha estado trabajando también con el doctor Kastner, que es la persona que dirige el grupo del NIH para la búsqueda de enfermedades autoinflamatorias, y específicamente su especial interés ha sido la deficiencia de DADA2. Entonces creo que tenemos la experta en el mundo y vamos a disfrutar entonces de esta charla. Como les dije, al final va a haber la doctora Ferguson va a estar conectada, entonces vamos a dar esta charla y después nos conectamos con ella para las preguntas. Gracias.
Hello there. My name is Dr. Amanda Ombrello, and I'm thrilled to be here today to talk to you about one of my favorite topics, which is the deficiency of adenosine deaminase type 2. And we're going to discuss what's new about DADA2 in 2023. I'd really like to thank the organizers for inviting me to be here with you all, and let's go ahead and get started. So, because some of you may never have seen DADA2, and some of you have probably only seen varying types of DADA2, let's go over a quick review about the disease we are discussing. And I think all talks begin very nicely with a story. So we're going to tell a tale of two little girls. The first is a 2-year-old little girl who was referred to Dr. Dan Kastner at the National Institutes of Health's Autoinflammatory Disease Clinic back in 2002. She was 2 years old, and she was referred because she had a history of fever, a history of rash. As you can see, she has livido racemosa on her legs, and she also had the interesting feature of having had 2 strokes. Now, Dr. Kastner was quickly able to say she did not have any of the known autoinflammatory diseases at that time, but he didn't know what she did have. So he continued to follow her over the course of the next decade, and he treated her fevers with the IL-1 receptor antagonist anakinra with some success, but he never really had a better diagnosis for her. And so she just would follow up periodically. Fast forward to 2011, and I was reviewing a chart for the Undiagnosed Diseases Program, and it was a 6-year-old little girl from Texas who had a history of fevers, who had a history of rash, much like the other little girls, and interestingly, she had had a history of 6 strokes. Now, 2011 were the early days for our group performing whole exome sequencing. So we were looking at patients who had phenotypic features that were unique. And although fever and rash are very, very common in our cohort, the fact that we had these 2 patients with a history of ischemic stroke was very unique. And so we sent their blood off for exome sequencing, and when the results came back, we found that they had variants in one shared common gene. And that gene was the ADA2, or formerly known as CECR1 gene. And what went from initially the 3 variants that these 2 little girls had has now expanded to well over 100 mutations that have been recognized in this gene. So we found this out, and we initially questioned, what is ADA2? We were more familiar with ADA1, both the gene and the protein, because when that gene is mutated, it can lead to a form of severe combined immunodeficiency that presents in childhood. However, ADA2 had never been seen in a disease like this. And so when we were analyzing it, we found that it was a homodimer that was highly glycosylated. And compared to ADA1, it was a secreted protein that had a much lower affinity for adenosine. We found that it was expressed in myeloid cells, monocytes, NK cells, and T and B lymphocytes. And we hypothesized very early on it might have growth factor activity. So we went about trying to investigate this more, and we got biopsy samples on our patients. And down here in panels D and F, you can see in a control without DADA2, they have a very nice, smooth vascular border, endothelial border here. But then when you look at the patients with DADA2, you lose that smooth, and it becomes much more jagged and interrupted. So they did, in fact, have endothelial damage. And then we knew these patients were inflamed, but we wanted to try and understand it more. So again, we took biopsies from patients and we stained them for the presence of TNF alpha via immunostaining. And down here in the bottom panel, as you can see, in controls without DADA2, they had this nice blue staining without any red. The red is indicative of TNF alpha staining perivascularly. And as you can see in the patients, they did have quite a bit of red TNF alpha staining around the blood vessels. So we take the patients who have the low ADA2 and find that they have this endothelial cell disruption. They have a overload of the inflammatory M1 macrophages compared to the anti-inflammatory M2 macrophages, and that these macrophages are having a lot of release of TNF alpha. So bring these two features together, and we saw a lot of those clinical features that we were seeing, such as the fever, the livido rash, the vasculitis, and the history of strokes. However, we quickly realized that we were only seeing one flavor of disease at that time. So how can these DADA2 patients present? Well, we now see that they have quite a bit of phenotypic variability, and published just last year in Frontiers Immunology was the 60 patient cohort from the NIH that we found had a lot of inflammatory and vascular features, such as the fevers, rash, and stroke. But there was also a subset that had a profound immune dysregulatory arm of disease, where they could have B cell, T cell, NK cell deficiencies, also diminished antibody responses to vaccines. And then again, there was a third arm of the disease that had hematologic features, such as the pure red cell aplasia, varying cytopenias, and all complete bone marrow failure. However, when we looked at our 60 patient cohort, we quickly found that really there were very few of our 60 patients that had just one feature of disease, and that most of our cohort had either two of the arms of disease present in their analysis, or 21 of our 60 patients manifested phenotypic features of all three types of disease. And then Dr. Pui Lee just published last year a more comprehensive list showing that DADA2 is really a multidisciplinary requiring disease, and that they can really, these patients can present to almost any subspecialty clinic. You can see that they have, of course, a neurological presentation, but they can also have hematological, renal, ocular, ophthalmologic, and also immunologic. So these patients could really present to any number of subspecialties, which means getting the word out there that DADA2 exists is very important. So these patients are recognized. So how do you test in a patient you suspect might have DADA2? Well, the two ways to screen would be to send genetic testing. You can do a Sanger sequencing for a candidate gene. You could send for one of those more comprehensive genetic panels for immune dysregulation or inflammatory diseases, or do exome sequencing and focusing in on the ADA2 gene. If two mutations are found, that solidifies the diagnosis. Additionally, enzymatic testing can be done. And this is especially beneficial in places where genetic testing is very hard to obtain. And we find that when you do the enzymatic testing of patients with DADA2, compared to normal, who have no mutations, who have normal levels of ADA2, and their carrier counterparts who have about 50% enzymatic activity, the patients with DADA2 have near absent to virtually undetectable levels of ADA2. So once you've made the diagnosis, though, in a patient, how would you treat DADA2? Well, based upon the finding that we had a few slides ago, and that there was staining for TNF alpha on their biopsies, our group at the NIH and others around the world started putting some patients cautiously on TNF inhibition. And we found that the fevers generally went away and the patients had increased energy. But over time, we discovered we weren't getting calls from the emergency rooms or from panicked patients and parents saying they had had yet another stroke. So our group at the NIH undertook analysis of 15 patients back in 2019 who, prior to TNF inhibitor initiation, had had a total of 55 strokes. And after TNF initiation in the 733 patient months, we found that those same 15 patients had had no further strokes, which was very statistically significant. We continued to do this analysis last year in our updated 60-patient cohort paper in Frontiers in Immunology, which continues to confirm that TNF inhibitors are highly protective in DADA2 patients when it comes to the stroke risk. So we knew the statistics showed that, but then again, we wanted to go back to the biopsies and see if we saw anything different after the TNF inhibitors were initiated. So the top panel again shows our patients over here on the right. These are controls that prior to going on TNF inhibitors had the presence of the red TNF alpha staining perivascularly. But in each of these patients after the fact, after TNF inhibitors were started, you can see that they have lost that red staining, meaning that there is no longer that TNF presence perivascularly. However, the TNF inhibitors do not treat all aspects of disease. The patients who have more robust hematologic features, such as pure red cell aplasia or neutropenia, often do not respond to the TNF inhibitors. Therefore, we refer them for hematopoietic stem cell transplant. Dr. Hassan Hashem just last year, along with others, published that there had been 36 patients with DADA2 who had undergone 45 transplants. So there had been some who had required multiple transplants. The most common indications were pure red cell aplasia, the neutropenia, a combination of the two, or pancytopenia. But they really remarked upon how there needs to be careful consideration to the pre-transplant screening, as well as the approach and the obstacles and special considerations to try and prevent these patients from having graft failure. That paper can be read in Frontiers in Immunology from last year. So knowing this, and as I'm sitting here talking to you, you may be wondering, well, how many people have DADA2? This is a question I get asked by families, clinicians, researchers all the time. And what I can tell you is the NIH cohort has about 70 patients in it now, and that based upon the literature, worldwide, there seem to be approximately 400 reported cases. However, just last year, Dr. Pui Lee and his colleagues did a comprehensive analysis trying to estimate what the carrier frequency of ADA2 mutations would be. And so what he did is he took, and his group did, is they took 100 of the known variants or predicted loss of function variants that when tested had less than 25% of residual ADA to enzymatic activity. And when they looked at population analysis, they found that the carrier rate, calculated the carrier rate worldwide was approximately 1 in 236 individuals. And then when you calculate that out further, you found that that was across all populations. But varying populations such as the Finnish, they had an increased carrier frequency of 1 to 160. And let's look here at the Latinos, right here in orange. The carrier frequency was estimated to be calculated at 1 in 227 people, with the most common variants being R34W, G47A, and A221T. So knowing this, the disease prevalence was able to be calculated at about 1 in 220,000 people. Now that still sounds fairly rare, but using the Hardy-Weinberg equilibrium, this calculates out to approximately 30,000 worldwide cases. And like I just told you a couple slides ago, or last slide, there have been reported about 400 cases. So clearly there are many, many unrecognized people walking around the world with DADA2. And we need to continue to learn about this disease, talk to the varying subspecialists, because there are people out there who could benefit probably from treatment or at least a good analysis so they can see how much disease burden they have. So we're going to talk about something a little bit different now, because we know that these patients with DADA2 have a lot of CNS vasculature problems based upon the strokes, but there's also a lot of peripheral vascular disease. So what's going on with that and how can we monitor it in 2023? These are just some pictures of some patients who have some of these peripheral vascular features, such as the pronounced livedo racemosa. And in this little boy, he actually has it extending onto his back and even up onto his cheeks a little bit. A little girl who has extension onto her abdomen of the livedo. And then there are the patients who have the cutaneous vasculitis that when biopsied could have been diagnosed as polyarteritis nodosa, but is actually DADA2. We have patients who have these unhealing ulcers or slow to heal ulcers that are caused by decreased blood flow down to the extremities as well as inflammation. This is actually the foot of a 40-year-old female with DADA2 who has had recurrent ulcers such as this. And then we have seen patients who have very pronounced Raynaud's, as in this young man here, or dry gangrene and necrotic digits, or a patient who also had involvement of his ear. This is the same young man who had the Raynaud's on his feet in the prior slide. And when he initially presented to the NIH in 2015, he had some evidence of peripheral vascular disease, such as some resorption of his fingertips. That over time, you can see he required a partial amputation of this finger, and he's also had a partial amputation of another one of his digits. Panel C here represents a normal angiogram on a patient, or not on a patient, on a normal individual that shows there's great blood flow down to the very tips of the fingers. But in our patient, you can see here, it almost looks like he doesn't even have tips of his fingers based upon the angiogram we did. So he was started on a TNF inhibitor, and we have continued to try to further understand what is going on in the vasculature and how can we further assess for this. Well, angiograms are wonderful, but they are invasive. We did MRAs, magnetic resonance imaging of the arteries in a number of our patients, and found that most of them were having normal reports. But yet it could look like they had very pronounced disease. So how could we monitor for this? Because the radiologist said we just weren't being able on MRA to perfuse down into the digits, the fingers and the toes far enough to see the damage. So we have recently started using the digital brachial index to try to assess for peripheral vascular disease in our patients. And around the world, there are vascular surgeons who can do arterial or ankle brachial indices to look at vascular disease in their patients, but they also have ways of doing it from the digits. And in the young man that we've seen his hands and feet in the past few slides, we can see when we did the digital brachial index on him, our DBIs, that on his right hand, you can see that he only had waveforms on DBI in his second digit. The rest of them are relatively flat lines. And when we looked at his angiogram, which we had, indeed, you can see that his second digit does have a vessel that does have better perfusion compared to the rest. So we said, wow, this really might correlate in these patients and is less invasive. So we repeated this just last week in a 16-year-old girl from Florida who had very pronounced Raynaud's in her history with some digital ulcers, and remarked that when her feet got cold, that they would turn purple and it would cause her some pain. So we had her just last week get a DBI done, and as you can see in her foot, her great toe had nice waveforms, and she had very weak waveforms in her second, third, and fourth digits, and a virtual flat line or lack of waveform in her fifth. Her angiogram, which had been done, showed again that there was really good blood flow coming into the feet, and went to about the metatarsal arch here. But from that point on, there were just very poor flow. But when you look at her great toe, she does have better perfusion into it, which is indicative by this waveform. And that when you look at her other second, third, and fourth, you can see that there is some evidence that there is, although not much, some blood flow getting to her toes. And there's got to be collaterals as well, because she does still have all of her toes. But the fifth digit, you don't see any great vessels that are supplying blood flow to the toes. And there's a flat line to correspond with that. So in summary, DADA2 results from biallelic mutations in ADA2. So it is a autosomal recessive disease. The phenotype, as I have shown you, crosses many, many subspecialties. And as we see, based upon the calculation, that there are 30,000 patients worldwide with DADA2, and we know of about 400. It is grossly underdiagnosed. The diagnosis can be made by doing genetic testing for mutations in ADA2 or enzymatic activity assessment. The current treatments include the TNF inhibitors, which are very good for the inflammatory features of disease, and hematopoietic stem cell transplant for those who have more of the hematologic features. And that based upon the history of these patients, you might want to consider screening of the peripheral vasculature, because it would be good to know if your patients are at risk for having potential digit loss over time. And we now know that MRA is not sensitive enough to pick up on this, and that something such as the digital brachial index, especially if abnormal, may prompt you to do some more invasive analysis of the patient, such as angiography. So what does the future hold? Well, I think the options are endless when it comes to this. We have developed a consensus statement. A lot of clinicians and researchers worldwide got together and have a consensus statement that has been prepared and is submitted for review. So I anticipate that that will be forthcoming sometime during this year, which will be of great assistance to clinicians around the world who are considering the diagnosis of DADA2 or having a patient who does have the diagnosis, needs to know how best to evaluate these patients so that they do not miss possible disease-affected organs. Gene therapy research is ongoing both in Italy and the UK, although it is still in the preclinical stages, but it is moving along. So down the road, we may have gene therapy available. Are there other treatments that one could use other than TNF inhibitors or the stem cell transplants? Well, this too is being investigated. There are some indicators that perhaps JAK inhibitors might be of use for certain patients, and other drugs too. And coming up just later this year in October of 2023, the 4th International Conference of Deficiency of ADA2 will be taking place just outside of Washington, D.C. in Maryland. And that is a great source for both the families and patients, as they have a patient and family conference that goes on as well, and the researchers, scientists, clinicians who are seeing these patients to get together and compile what we know, where we are going as far as this disease and its future. The research I do could not be done without the help of my team that you can see there. And we also have a very large multidisciplinary team of doctors and researchers who have seen our 70 or so patients at the NIH, who have become a trove of knowledge when it comes to DADA2 and the related features that patients may have. And of course, the Kastner Lab and Dr. Ivona Oksentievich have been so very helpful as we struggle to continue to expand our knowledge of this disease. I'd like to say thank you to the patients and families around the world who have been so generous with themselves and their bodies to help us further our research. And should you have patients that you would like to discuss, or you have a patient that you think you might have who has DADA2, you're free to reach out to me, Amanda.Ombrello at NIH.gov, or my nurse practitioner, Lorena Wilson at NIH.gov, and we would be more than happy to be a sounding board for you going forward. Again, thank you so much for allowing me to be here. I hope I have brought some of the newest information on DADA2 to light for you, and let's go and find some more of these patients that haven't been diagnosed yet. Have a wonderful rest of your day.